Yeah.
I'm moving my, and I'm gonna let people in, and then you're gonna take over. I may have to pull this arrow back from you time to time to let people in.
Okay.
That makes
Yeah,
sense.
because we have changed slides.
Yeah, you want to get it back before I let them in. Can you do that?
I'm trying to figure out. I don't think
I can't do it.
can.
But
Oh, it's
use
me
your
again.
arrow, maybe you're back, and there you go. Previous. Okay. Here we go.
Oh, moved it again.
Yeah, I'm sorry. I'm trying to admit now. You take it back. Welcome in, everyone. Welcome to Care Concierge with CarePatrol, where education is the heart of everything that we do. We educate our families and aging adults about the care continuum, what's in their path, and what resources they need to marshal to meet that new demand on the health care and wellness of a loved one. We educate our referral sources, such as social workers and nurses, such as all of you, on the work that we're doing for your patients and clients. And then we educate providers who we work with in various ways. And we let them know if a resident is appropriate or inappropriate for their community. And in all of those ways, again, our goal is to educate and advocate and offer advice. And if our clients move into a community or use a service that we have advised them to use, then we're paid commission, and otherwise we're free. So if you're ever thinking about someone who has a question or has a need about aging care or the healthcare continuum, we're happy to talk with them, and it's no charge. And so I hope you'll be comfortable recommending CarePatrol to your clients and patients. Today, we have Ginger Bentley, who some of you who have been with us regularly may remember had worked with us a few weeks ago to discuss wound care. We were just talking, Ginger and I, before this presentation about how much I learned from that teaching and how excited I am for today's teaching. Ginger's a terrific instructor. She's a nurse and has spent her adult life, her career as a nurse. She's been a PICC Line nurse since 2002. And so we're going to benefit today from 20 years of great and deep and educated experience on Ginger's part and learn more about this very important aspect of healthcare and of care that all of you are providing. Now, I have made a technical error today. So every time I make a move, Ginger's screen changes. So if you see it moving back and forth, please be patient and just always realize that when there's a user error, I am that user. So it's always me. And I apologize, y'all. I'm technologically challenged. My wife controls the remote. I do not. And so today, if there are issues, again, I apologize, but I hope it's not distracting from Ginger's teaching as again, I know it's going to be so, engaging for us. It looks like it's a Friday, it's a holiday, it's Veterans Day. And if you served or someone in your family served, I want you to know that I thank them. And I'm sure many of us on the line thank them for that service. It's no small thing. And as we just know, we had an election in this country, and it is the service people who make those elections possible. We would not live in a democracy without our servicemen and women. So we thank you. As we get on now, as folks are entering our classroom today, I'll give it just a minute more and remind you that Care Concierge is an educational series that we started in April of 2021 in response to COVID and the lack of CEU opportunities for folks. And we've continued doing that now, even as COVID is Well, is it over? Is it not? That's a good question. But nonetheless, we've continued to do these and they've been well received. We appreciate you for being here with us today. And we know that you have many options to receive education. And so the fact that you've chosen this hour with us means a lot. Again, I believe we're all in. So I know Ginger has a lot to cover today. Ginger, I'll let you assume control of the screen and introduce the topic. And again, I'm so appreciative of you for making time for us.
Thank you for having me, Sean. Wow. So many things in that. Number one, that I've been doing PICCs for 20 years. I have not thought about that. Kind of made me cringe a little bit. Been nursing longer than that, but still, it was just kind of weird hearing that. Like Sean said, I've been doing PICC Lines, obviously, since 2002. I currently work PRN for a vascular access team, which includes a lot more than PICC Lines. Sean and I were discussing that before everything was getting going. So there's lots of things that we could talk about. Today we are focused on PICC Lines, though. And I could be the reason for the technical error because I am very technology challenged. I can't get that out. Technologically challenged. Anyway.
Hard word.
Obviously can't say that either. So I can say the other stuff that we're going to talk about today, though, I promise. So let's get started with PICC Lines in general. So I'm going to see if I can make this work and go to our next slide. Let's see. Next. Yes. Okay. So we're going to talk today about PICC Lines and contraindications of PICC insertion. I think. There we go. Contraindications of PICC insertion. We're going to understand how a PICC line is actually inserted. We're going to discuss the role of nursing with PICCs as far as maintenance and care goes. And then we're going to discuss removal because I know that a lot of facilities and home health care agencies end up having to remove PICC lines once they're done with them. So I wanted to kind of touch on that too. So let's kind of get on in. Let's see. So let's talk about what is a PICC. So I know that you hear the word PICC, but it never really registers a lot of times that a PICC line is a central catheter, which means that it is sitting at the tip of the heart or the SVC-RA junction, which means the superior vena cava and the RA junction. So the PICC line, I'm going to pull this up over here too, because when it changes, it kind of messes me up a little bit. So, okay, there we go. So the PICC line is inserted by a certified nurse or a physician. When physicians insert the PICC lines, they usually insert them in interventional radiology. A lot of facilities do not actually have MDs that actually insert the PICCs because it's much cheaper and easier to have an RN do that. RNs cost a whole lot less, and you don't have to actually take the patient out of the room to the physician. So PICC lines are inserted at the bedside by a certified nurse. That requires obviously special training, and then you are required to place a certain number of lines to show that you are competent. It is a modified Seldinger technique, and it is sterile. So there's a lot that goes into inserting a PICC line. The reason it's sterile is because it is inserted into the upper arm, and it actually runs all the way along the vein up to the SVC-RA junction or the superior vena cava. So as we said, it is inserted at the bedside, and there's certain veins that we use to place the PICC line. So the veins that we use typically are the cephalic, the basilic, and the brachial veins. If you'll look, I kind of put you a little picture up here because I wanted you to see what those veins actually were and how that actually happens. The PICC is inserted. The cephalic vein isn't always the best vein. You see, it's the one on the outside of the bicep, and it kind of takes a little curve into the axillary vein and the subclavian vein. So when that curve happens, sometimes it does not thread through easily. And so the cephalic vein is not an optimal vein to use. The main veins that we use are the brachial and the basilic. If they only have a cephalic, then we will do that, but we try to use the brachial or the basilic veins. The brachial vein, you can have some issues when you're placing a PICC line in the brachial, which is obviously runs along the brachial artery. The issues that you can have are there's a lot of nerve bundles around that area. And when you go to stick the patient, you can activate the nerves. So if you activate the nerves, the patient will holler out and jerk their arm because they have a sharp pain shooting down their arm into their fingertips. So obviously you have to abort if that happens. The basilic vein is the best and easiest. You can see how it follows up and kind of just doesn't take a sharp turn going into the subclavian vein. All of these veins, though, are used. We always go in the bicep area. Sometimes you will see a PICC line actually inserted into the chest. If that is the case, then that was done by the interventional radiologist. So, PICC lines, if I can get the next slide. Facilities can place, what facilities can place PICC lines? So inpatient facilities, such as an acute care facility or an LTAC facility, place PICC lines. So if you want a PICC line placed, it needs to have chest x-ray capability. So some nursing homes may be able to place a PICC line if they have on-site chest x-ray capability. If you don't have the on-site chest x-ray capability, then you can't have the PICC placed. Even though there's different ways to actually verify PICC placement, some of those ways don't always work 100% of the time. So you may end up having to have a chest x-ray and you wouldn't be able to get placement if that's not readily available. Facilities, a lot of the facilities, as far as the acute care facilities, do outpatient PICC lines. So you can always call the hospital, your local hospital, and find out if they will place an outpatient PICC line if your patient needs one in a home health setting. Even nursing homes can send patients to the hospital for an outpatient PICC line to be placed also. What you will see in most nursing home or rehab facilities, as far as lines being placed there, would be more of a midline, because a midline can be placed without having to have chest x-ray confirmation. But a PICC line is different than a midline in many ways. And one reason why you would want the PICC line is because maybe the patient needs extended antibiotics or they are receiving medications that are vesicants. So let's talk about why you would want a PICC line or how you get one. You have to have a doctor's order to obtain a PICC, and you have to have a signed consent. Therefore, the patient has to be alert and oriented in order to have the PICC line placed if there is no family to sign the consent. If a patient is going to be in the hospital for a prolonged stay, then a PICC line may be the option for that patient because it'll decrease the sticks and lab draws for the patient. So it provides comfort for the patient. Same with an acute care facility. Vesicant medications, so there's certain medications that a patient may be receiving that are going to be more harmful to the veins. Some of them are just irritants, some are vesicants. If it's a vesicant, some of those cannot go through a peripheral IV at all, because if they infiltrate, it will cause tissue necrosis. So certain medications can only go through a central access. Therefore, a patient may need a PICC line just for the particular medication they're receiving, even in the hospital setting. Home medications that patients may receive PICC line for would be IV antibiotics, cardiac or renal medications like milrinone or Cardine or Cardiazem. Those type things are given in the home setting. And then obviously chemotherapy, that may be a good reason to have a PICC line also, is if you are receiving chemotherapy.
So are you saying that there are certain medications that can't be delivered in another way, and this is why they're delivered by a PICC line?
Yes. So there are guidelines as to what can be given. And I think I have that at the very end of this. I do. So yes, there are medications that cannot be given peripherally and cannot be given through a midline. So in that case, you have to have a central access. Doesn't have to be a PICC line, but it does have to be a central access, which means it could be just a regular CVL, it could be a Groshon catheter, it could be a port, it could be a PICC. So there's other options as to what they would have to go through. Obviously, a CVL or a central venous line is not something that a patient would be discharged from a facility with. So that's not going to be a good option if the patient needs a specific drip that cannot be given peripherally. Does that make sense?
It does. And so the other thing that I'm confused, what is a midline?
So a midline is, they look like PICC lines, but the tip lies in the axilla. So where we looked at previously, let's see if we can go back to that slide to show you what I mean by that. Okay, so when we look at this right here, this arm over here, and we're looking at the cephalic, the brachial, and the basilic veins, and we said that a PICC line runs up those veins and goes into the superior vena cava. Okay, so it's going to run through that axillary vein into the subclavian vein and into the tip of the heart. The midline, however, will only go into one of those three veins, and the midline will sit right at the axillary vein. And so it is not a central access. It is still considered peripheral.
Okay.
That make things clear as mud?
As mud, yeah. So why would you not do the midline?
So midlines are usually for a shorter term antibiotic. So usually if the patient's only going to be getting an antibiotic for 7 days or 28 days, then a midline would be the more appropriate option. If they're going to be getting the antibiotic for 6 to 8 weeks, then a PICC line would be more appropriate, because a midline is considered more of a shorter term line. Also, those certain vesicant medications can't be given through a midline. They can only be given through a PICC line. Something else that can only be given through a PICC line would be TPN, or total parenteral nutrition. So that would be something that you could not give through a midline, only a PICC line.
Okay, I've messed up your presentation. There we go. Now you can take it.
Yeah, hold on. Let me get us back where we're going. It takes a minute for to catch up. Okay, so let's move on to dwell time. So let's talk about dwell time. We just talked about a midline can only last for a month or so. Ideally, really, in real life now, that is what the 28 days is what the manufacturer actually recommends for a midline. In real life, the CDC and INS guidelines now state that there is no dwell time for any line. So a midline could technically stay in for as long as you wanted to use it, according to the CDC and the INS. The INS is the Infusion Nursing Society, and that is like the best practice holy grail for knowing what line or how to care for lines and all of that good stuff. They make the recommendations on all that stuff. So according to them, even a peripheral does not have a dwell time anymore. Used to, we said peripherals had to be changed every 96 hours. And now the INS states that a peripheral does not have to be changed unless clinically indicated. So what do I mean by clinically indicated? I mean that when you're looking at a peripheral or a line, any type of access, if it looks infected, if it looks infiltrated, if it's swollen, it's not working, that's clinically indicated. So you can actually keep a peripheral now for 14 days if you want to. As long as it's not infected looking, it's not draining, it's functioning properly, and it's not painful, then it's clinically indicated to keep that line. You do not have to change them out anymore.
And so I'm going to continue to ask stupid questions. And here's
Nope.
another. What is dwell time?
So that's how long it can actually stay in.
Of course. Okay.
Yeah. So the longest recorded PICC line is 7 years.
Wow.
So a PICC line can hang tight for a while if you take care of it. That's one of the biggest things, is taking care of the PICC line so that it can stay and get the patient the benefits they need. So most patients are not going to keep a PICC line for 7 years. I don't know why that particular patient had a PICC line for 7 years, but normally, a PICC's going to usually run its course. The patient's only going to need it for about 6 to 8 weeks if we're giving it for IV antibiotics. Some of them will need it a little bit longer if they're getting TPN at home for some reason to kind of bridge them to get their nutritional status where it needs to be. But for the most part, a PICC line usually is a temporary access, unless they're receiving it for chemotherapy, and then however long their chemo goes would be how long their PICC line would need to stay. If you're not using the PICC line anymore, though, then you should take it out, because that's just a source of infection, and you can get what we call a CLABSI, or a central line associated blood infection.
And so again, the PICC line nurse or doctor, PICC lines include ports for chemo.
So no. So a port is implanted underneath the skin, and it is accessed with a needle when you need to actually give the patient the particular medication. A port is best for something like chemotherapy, because it's something that can stay with the patient and it will last them for years and years to come. Also, it's better because it's not something that a patient has to maintain at home on a daily basis or worry about pulling out, because it is implanted under the skin in the upper chest. You do have to be put under sedation, because it is done in the OR by a physician. So there's those things to consider also.
Okay.
So let's talk about some contraindications with a PICC line placement. So why would we not place a PICC line? So nephrology would be a big reason why we would not place a PICC line in your patient. If your patient is seen by a nephrologist, there is not going to be any PICC nurse that is just going to say, okay, let's put a PICC in. When a PICC nurse gets an order for a PICC line, they want to know what medication the patient's going to be receiving, how long the patient is going to be receiving the medication, and we want to know a history about the patient. So if the patient is a nephrology patient, it's very important for us to know, because I've put this over here for y'all to see. You remember we talked about the cephalic, the basilic, and the brachial veins? And I've got that picture up there to show you. But if you look over to the right, those little circle diagrams, those are showing you that nephrology uses the same exact vein that we use to place PICC lines. So they're going to use your brachial and basilic veins to place a graft or a fistula in the upper extremity. If we place PICC lines in a patient who may need a graft or fistula down the road, then we're going to scar up those veins, and then they will not be able to get a graft or a fistula for dialysis. So nephrologists look at that. Maybe you're just starting out in renal failure, and we will not place a PICC line in you if that's the case, unless nephrology says that's okay, because we don't want 2 years from now you to need some type of graft or fistula, and they can't do it because your veins are scarred. So we're very particular on that front. So if you have a history of a DVT or a blood clot in your upper extremity, sometimes even your lower extremity, we kind of prefer not to really place PICC lines, simply because that is a big risk with PICC placement, is DVT. because you're putting a catheter into a vein, and the catheter to vein ratio, which means the catheter size and the vein size, may be a little similar, and it can cause a little friction in the vein that can cause a blood clot. So if you've had a blood clot previously, you're obviously more prone to developing blood clots. So we're going to be a little bit skeptical of putting a PICC line in you if you've had previous blood clots, because that is one of the risks of PICC line insertion. So we don't want to cause you to have a blood clot. Also, if you have infection in an extremity, we are not going to place a PICC line in that particular extremity. So you have an infection in your right arm, we're not going to place the PICC line in your right arm. We would definitely go to the left. If you have limited movement or you're contracted, it's going to be difficult to place your PICC line, because to place a PICC line, you need to be able to put your arm out like this. And so if you're contracted, I can't get your arm out to be able to see those veins that I need to get to. So if you have a contracted patient, a PICC line may not be your friend. If your patient has had a history of shoulder surgery and can't move their arm out, then that may not be your friend either. And then we talked about limited vein size can cause a DVT. Sometimes though, because we do use ultrasound to actually visualize the veins before we place the PICC line. So when you're using the ultrasound, you assess all three of the veins that we would normally use. And if the veins are too small, catheter to vein ratio, we will not place a PICC, because I can't put a larger catheter into a vein that is smaller than my catheter. And so I have to be mindful of that and say, you know what, their veins are too small. We cannot place a PICC. So sometimes that can be a contraindication as well.
So you judge the thickness of the vein with what? How do you know that the vein
So
is not?
When you're placing a PICC line, your ultrasound machine actually has these little circles to the right of your ultrasound image. And there's like one that says 2, 4, 6. It's telling you what size French catheter could fit in a vein that was approximately that size. So when you're looking at your vein, you're also looking at this guide over here that tells you, oh, if it's this size, you can only put a 3 French catheter into this particular size vein. Well, if I need to put a 5 French catheter in it and it can only accommodate a 3 French, then I probably don't need to put that catheter in.
Okay. That's fascinating.
It is fascinating. It's very interesting and actually very fun to be able to place PICC lines. So I wanted y'all to see, you see I've got arrows on this chest x-ray because I wanted you to see PICC confirmation. So there's 2 different ways that you can get PICC confirmation. And what I mean by confirmation is after we place it, is it sitting in the right spot? Is it in the SVC-RA junction? Okay. So how do I know that? Well, number 1 way would be chest x-ray. And remember I said you can't place a PICC in a setting if you don't have chest x-ray capability. So this is why. So I need to get a chest x-ray to confirm placement to make sure that we can use this PICC line. So if you see my blue arrows coming from the arm going up, that is how the PICC line travels. And you can faintly see a PICC line on this chest x-ray. That's what the blue arrows are actually pointing to. It's very faint and hard to see, but you kind of can see it if you know what you're looking for. But anyway, so the blue lines, that's how the PICC line travels up and goes in and sits at the SVC-RA junction. So it's showing you that last blue line, blue arrow over the heart area is where that PICC tip is sitting. Now, the problem with chest x-ray confirmation is it's a best guesstimate. So what do I mean by it's a best guesstimate? Well, when you place a PICC line and you get a chest x-ray, can you look at the chest x-ray and say, oh, that's the SVC-RA junction. I can tell from the chest x-ray. You can't. You can say, well, that's 1, 2, 3 ribs, and that's where it should be, is at the 3rd intercostal space. which means between the third rib cage. But that's not everybody's anatomy. Everybody is built differently. And just because we say that a PICC line should be at the third intercostal space, and that should be your SVC-RA junction, it may not be yours. It may be mine. It may not be your friend sitting next to you. So it is a best guesstimate when we're looking at a chest x-ray for confirmation. All we can really say by looking at the chest x-ray is that it's in the SVC. You can't necessarily get real accurate placement saying that it's SVC-RA junction. Now, however, let me get that out of there. No, let me go back. Technical difficulties, I told you. Okay, however, there is a technology called 3CG technology or ECG technology. So that is the most accurate way to get placement verification. Okay, so if you look, what we do when we place a PICC line, or some facilities do, not every facility. I'm used to this. We didn't have this back when I first started learning PICC placement, obviously in 2002. This was not something that was out there, but PICC confirmation has really changed over the years, and now you can do an EKG essentially to find out if the PICC is in the correct place. So what happens is the PICC line is placed, and we put two leads, a red lead and a black lead, on the patient, on the outside of the patient. The PICC line has a lead inside of it. So the lead that is in the PICC line is going to be your third lead for your ECG. So you're watching a screen as you're placing this PICC, and as you place it, your ECG will start to change. You will notice some changes in the ECG, and the changes that you will notice are, if you see number 1, the PICC line's going in, but it's not in all the way yet. So you can see a P wave, and then the next spike is a QRS wave, and then you get the T wave. You are looking at the P wave. That's what you want to monitor when you're placing a PICC line. So if you look at the number 1 on this screen of the heart and the PICC line going in, you can see that there's a P wave, that first one before that large spike, and it's a decent size. When you get to number 2, you can see the line coming down in towards the heart more. And you see that P wave, that first elevation, goes way up from what number 1 was. So you are looking for the highest P wave elevation without negative deflection. So what does that mean? Okay, well, number 1 has P wave elevation. Number 2 has really good P wave elevation. Number 3, do you see where we've advanced that PICC line just a little bit further? If you look down on that first wave, that is negative deflection. Do you see how that line's coming straight across and then it goes down and up? That's negative deflection. So that means I'm in too far. And if I'm in too far, that means I could cause the patient to have an arrhythmia. That has happened before. So it's not terrible. It's not lethal. The patient will tell you, oh, my heart feels weird. It's doing something funny. And you're like, oh, okay. So you just pull it back some and everything's fine. But obviously you wouldn't want to leave it in like that, in too far. So that's how you know that you have perfect placement of your PICC line and that it is in the SVC-RA junction. Number 2, if you look, it's boxed up and it shows you where your PICC line is sitting up at the little heart diagram. And then at the bottom, you have the highest P wave elevation without negative deflection that you get in number 3. So if you see in number 4, you have a lot of negative deflection. It dips down a lot further in number 4. So you definitely want to avoid that, because most likely if you've got that much negative deflection, they're going to be telling you that they feel their heart doing something funny. So you just pull back out a little bit and get to the number 2 ECG and you're good. So we do take a little picture of that ECG and we upload it or print it out, however you do your EMR system. And that is what we use as confirmation. Now, if you get ECG confirmation, you do not have to have chest x-ray confirmation. Because remember, ECG confirmation tells me it is in the SVC RA junction. It is the most accurate confirmation that you can get of a PICC placement. Chest x-ray is your guesstimate. ECG is the Bible. Does that make sense? Does anybody have questions?
I wish they would. You know, I have so many questions. I feel like I'm the only one that has no clue of what's going on.
I'm sure you're not the only one. Maybe everybody else is eating since it's lunchtime. So
True.
okay. So when we talk about that, the tip lies in the SVC RA junction. I'm going to move myself over a little bit so I can see. Okay, so the tip lies in the SVC RA junction, and this is what that looks like. So you can see the PICC line hanging out of the body. This PICC line was inserted into the brachial vein, and it follows the brachial vein. You can see it's white inside the vein, and that can tell you a little bit about catheter to vein ratio. There's a little more blue going on, so there's some room in that vein. So you're going to be at less risk of creating a DVT on that patient. So it goes into the brachial vein and it follows up, goes into the axillary vein, into the subclavian vein, and sits at the SVC RA junction, or the tip of the heart is what we tell the patients. It's going to sit right at the tip of your heart, but you won't feel it and it won't cause you any problems. And the patients don't feel it. Insertion. A lot of patients get real anxious when we start talking about putting this in because we've told them this is going to go and sit at the tip of your heart. Okay, well, that freaks everybody out. Freaks me out a little bit thinking that you would do that to me. But we numb it up when we place the PICC line, and so it actually hurts less, most patients say, than an actual peripheral IV. So it's numbed up, we insert the PICC line, and they feel nothing after the numbing, and then they may feel a little pressure of pushing into the vein. But other than that, it's not painful for the patient at all. It sounds painful. It's scary for the patient because we do, remember we said it's sterile. So we do we have on hats and masks and gowns, and there's a drape over the patient's head and all the way to their feet. And so it looks very scary, like you're in the operating room at the bedside, but it's not that terrible. PICC line can be placed pretty quickly, actually. It really just depends on who's placing it, how much experience they have. Is there one person placing or two? Are there complications with placement? But you can place a PICC in 15 minutes if you are experienced.
We have a question from Miss Alexander, who, by the way, I want to thank for a really sweet note she'd written earlier today in the chat room. But her question is, can a person die from getting a PICC line?
You mean like with insertion? No. So yes. There's less risk with insertion of a PICC line versus having like a central venous line placed by a physician at the bedside. You can die from a central line placement at the bedside simply because you can cause a pneumothorax or a hole in the lung. With a PICC placement, there is no risk of pneumothorax. And because you're not poking anything up here into the chest, it is going peripherally. So that would be the reason why, the only reason why somebody would die from a line placement like that would be from a pneumothorax, but that's not even an issue with a PICC placement. So it is very much more patient friendly. The only reason why somebody might die from a PICC line would be if the PICC gets infected and they get septic, but not from the insertion itself. The biggest thing would be that the patient with insertion would have an arrhythmia, or it may go up the patient's neck. So that does happen sometimes when you're inserting a PICC line. Instead of it going and following the patient's vein and going and sitting down at the tip of the heart, sometimes it comes in and it follows and it goes up and sits in the jugular vein, which is kind of a problem. We don't want it there. And when we flush the PICC line, they can hear it in their ear being flushed. So that's kind of freaky to the patient. If they tell us that, then obviously we're going to kind of redo some things that we're doing. There's some few troubleshooting techniques that you would do. So obviously you would pull the line back some to about right in here, and then you would try to maybe double wire it or flush it as you're inserting it. You're going to want to move the patient's neck down to try to cut that little area off some, so it's not just such an easy access. Some people's anatomy just make it to where it will not go and drop down. And so some people can't have PICC lines for that reason, that it just will not go into the correct spot. Care and maintenance of a PICC line, they're actually pretty easy to take care of. They need to be flushed every 12 hours with 10 cc of normal saline. That's one of the biggest things that we find that does not get done, is they don't get their routine flushing. If you're not flushing the PICC line like you're supposed to be, then it's going to get clotted, and that's going to increase the patient's risk of infection. So you can draw labs from a PICC line, but again, you have to make sure that you flush the line, because if you're not flushing the line after you draw the labs, then some blood's going to get kind of dried up in there, and it's going to cause some issues with giving the medicines or pulling back blood from that point on. And then obviously blood sitting somewhere does build up bacteria and cause infection. So
how do you flush it?
Do what?
Does it flush into the heart? How do you flush the line?
It does. So you just connect, just like if you had a regular IV, you just connect the saline to the lumen, and then you just flush. So it does go directly into the heart, but there's 50 liters of blood that's pumping out of your heart every minute. And so once it goes there, it just goes right back out to everything else very quickly.
Okay.
So what we do recommend is to power flush your line. So what we mean by power flush the line is when you're flushing, when you're in nursing school, you're taught to flush something slowly and give it over 3 to 5 minutes. And okay, well, when you're flushing a line, we don't want you to do that. We want you to use the palm of your hand, and we want you to flush, flush, flush. That is called a push-pause technique. Okay. The reason we say that is because, so say you're washing your car. Okay. You've got the hose. You don't have the sprayer on the end. You just have the hose, and you're taking the hose. You've got soap all over the car, and you're taking the hose and you're just holding the hose over top of it. You don't have your thumb on the end or anything. You're just holding the hose on it. Is that cleaning off the soap off of your car? Not very well. If you take your finger and put it on the end of the hose, it gives pressure, and the water goes like this instead of like this, and flushes off your car or cleans off your car. Okay. So if you're taking and flushing your line and you're just flushing it slowly, you're basically just letting the water drip on your car. If you take it and you push pause, then you are pushing and cleaning out that line with every push you give. And so that's very important that you're flushing appropriately to make sure that you get the line cleaned out. So there's a lot of thing with clamping the lines. So that's a big thing to talk about. It depends on which cap you use as to if you actually clamp your line or not. So that is a big deal. And we're going to talk about that in the next slide. So cap changes, obviously they should be done per your facility's policy. You should always scrub the hub before you access any site with an IV. Doesn't matter if it's a peripheral or central access, but you should always scrub the hub. They make little things out there. You can use alcohol wipes, CHG wipes, scrub hubs. There's all different kinds of things. There are some caps that are already CHG impregnated that you place on the lumen, and those you don't have to scrub the hub now, but we always say scrub the hub to make sure that you are cleaning off that lumen. If that lumen has been sitting on your patient and laying in the bed with them, everything they've eaten or drank or vomited is on that lumen. So you don't want to just connect into that lumen and flush whatever that is into their body. So you want to make sure that you're definitely scrubbing the hub. Caps should be changed weekly or every 96 hours according to your policy. And then obviously care and maintenance of a PICC line requires you to actually watch the line, make sure that there's no swelling or drainage from the site. So if there is a lot of swelling at the site, then you may have a DVT in that arm. Now, current INS recommendations do not recommend taking a PICC line out if there is a DVT. The current recommendations say to leave the line and treat the DVT. If you take the line out, then whatever you had the line for, you now can't give your patient, whether that be TPN or antibiotics. So you want to leave that line and treat the DVT with the line in. If you're having drainage or redness at the site, then obviously there may be some infection. The line would need to come out. And if you're having fever, which may be a better indicator of infection or an increase in white blood cell count, then if there's no other cause, like there's not an active UTI or they don't have pneumonia, then you should think about that this could be related to the line and maybe the line needs to come out. So we're going to talk about to clamp or not to clamp, I think. No, I don't know what I just did. Oh, there we go. Yay. Okay, so to clamp or not to clamp. So there's lots of different, there's lots of different caps out there. And so I wanted to kind of go over this because a lot of people say that they clamp the line. A lot of people say that they don't clamp the line. And so it really just depends on your caps as if you need to clamp the line or not. So if you have a positive displacement, that I cannot say, obviously, a positive displacement cap, then you want to make sure that the fluid, let me start over. Positive displacement caps mean that when you remove your syringe from your line, fluid is going to jut out the end of the catheter. And so you do not want to clamp a positive displacement cap before you disconnect the syringe. Because when you disconnect the syringe, that's going to jut out. And if you clamp it, it doesn't jut out. Positive displacement caps, some people say, will help keep you from getting a clotted line because it does give you that extra little push at the end, instead of some caps can cause it to kind of suck in a little bit. So the ones that cause it to suck in can cause there to be like a little clot on the end of your line, which causes some issues with it continuing to work. So neutral caps will actually, you disconnect, but you clamp before you disconnect the neutral cap. And then the negative, it's kind of a little bit of both. You want to clamp the negative while you're flushing. So there's all different types of caps, but that's the three main kinds of caps. And so you should know what your facility uses to know what you should be doing. Should you be clamping the line or should you not be clamping the line? With positive displacement caps, you usually don't clamp the line at all. So the neutral and the negative will require clamping, just at different times. So just be aware that there's reasons why you clamp and don't clamp, and you should know what your facility uses as far as caps go to know what you should be doing. So with removal of a PICC line, any nurse can remove a PICC line. That doesn't require special education or training. You just pull the PICC line. So you'll follow your facility's protocol, obviously, but any RN can do that. Now, your facility may say that they have to be checked off, and that's perfectly fine, but it's real simple to pull a PICC line. The only things that you have to do, obviously remove the dressing, You're going to pull on the line firmly, should not have any resistance. If you do meet resistance, I would not continue pulling because it should come out very easily. We have patients all the time that say, oh, it just fell out in my kitchen floor. We're like, how does it just fall out in your kitchen floor? We're talking, it goes from here to here. Those things are 40 centimeters long sometimes. Sometimes they're 50 centimeters long, depending on how long the patient is and how big the patient is. So how does it just fall out? So if you meet resistance, don't pull. If you don't have resistance, then you just pull firmly. Ask the patient to take a deep breath and hold it, and then you'll just cover it with the gauze. When you remove the PICC line, you should always note the length of the PICC to make sure that everything came out and that you didn't leave anything in. Therefore, if you're in an outpatient setting, if the patient came from an inpatient setting and you're in an outpatient setting now and you're removing the PICC, they should have sent with the patient the measurements of the PICC line so that you know when you pull that PICC line that you got all of it out and you can look at the measurement.
Okay.
So some other types of central access I thought we would just kind of briefly review are Groshon catheters. We moved again.
Me.
Oh, moved again. Okay, so Groshon catheters, which are long-term catheters and they are tunneled. They are placed in the OR by a physician under sedation. And so they come out of the chest. They're usually a blue color that hang out of the chest. Why would you get a Groshon catheter? Okay, you would get a Groshon catheter if we can't put a PICC in you. Why can't we put a PICC in you? You've got a history of DVTs, nephrology, or you've had so many PICCs that you have scar tissue and a PICC won't go anymore. So those are some simple reasons why we could not place a PICC in a patient. So if you need antibiotics or long-term medications, then you would need to get a Groshon catheter placed if a PICC line's not appropriate. Hickman catheters are very similar to Groshon catheters, except for the ending of them, the ending on the inside, not the outside. But they are placed very much like the Groshon catheter is in the OR by a physician. Same reasons why you would get a Hickman versus a Groshon. Although I have not seen many Hickmans in recent years. That's something that we used to do in the 90s a lot more than Groshons actually, but I haven't seen a lot of Hickmans lately. So that may be being phased out. Central venous lines are temporary lines that are placed by a physician at the bedside. They're placed much similarly to the PICC line, except that you do have a risk of pneumothorax, which is what we discussed earlier. So a lot of times a PICC line is way more appropriate because there is less risk for the patient. PA catheter is also something that we have in an inpatient setting, but a PA catheter is used mostly with heart surgeries because it's larger, and then it's converted over to a central line. They don't usually keep them very long, so that's not something you would ever see in an outpatient or long-term care facility. So an implanted port, we kind of discussed that a little bit earlier, and it's placed underneath the skin in the upper chest, and you actually have to take a needle and access it. So reasons you would want a port would be for intermittent infusions like chemotherapy, or if I needed IVIG, those, or I have no veins and can't get peripherals on me, or I can't get good lab draws, just have had a hard time with that over the years. So some people get ports for that reason. Now, a port is mainly for intermittent infusions because you have a needle sticking out of your chest. So if you're getting continuous infusions, ports aren't normally where we go to first, because you're going to have to leave that needle in for an extended period of time. That needle has to be changed every 7 days. And you don't want a patient sitting at home or in a facility with a needle sticking out of their chest with a dressing on it. You're just at risk for infection in that setting. So if a patient is going to be getting continuous infusions, then these other options, a Groshon, a Hickman, a PICC would be a better option than a port. A port is more for the intermittent type things. Trialysis catheters and perm caths are very similar. They are for dialysis. Perm caths are not used by nursing. They are only used by the dialysis nurses, and a trellis catheter is used in the inpatient setting or long-term acute care setting for temporary dialysis or until they can get a perm cath or permanent catheter. And those are placed in the OR by a physician as well. So we are almost wrapping it up. If I can get my computer to take us to the next slide. So the next slide is, remember we discussed vesicant medications and catheters selection, why you would get one catheter versus another. Well, this is why. So this is just a little guideline that you can go by to see what medications can go in what type of line. So these are called vesicant medications. Some of them are irritants. And if you look, there's a common medication in hospitals right now. I don't know why we're running a special on amiodarone, but amiodarone is our special currently. And if you look, it's the second one from the top. And so under peripheral, it says peripheral allowed. It says yes, if large lumen vein and not to exceed 24 hours. So amiodarone we used to give all the time through a peripheral IV. Now it's come to light that that's probably not best practice, and it shouldn't go through a peripheral line more than 24 hours, which means if you are giving it through a peripheral every 24 hours, you have to change that IV. Good luck, because most patients are not going to let you stick them every single day. It is allowed through a midline, if you see in the next column, and it's also allowed in a CVL or PICC, and it's actually recommended to go through central access. So this is a great little tip sheet if you're not sure if your medication can go through a certain line or not, especially through a peripheral. It will tell you if it's an absolute no or if it can for a certain period of time. Dobutamine is an absolute no in a certain concentration. So if you look about midway down, dobutamine, if it's less than 5 mics, can go through a peripheral for 24 hours. It can go through a midline or a central line, but if it's greater than 5 mics, it cannot go through a midline or a peripheral and has to be central line. So this is just a great little tip sheet to have. It bases the medications off of their pH and their osmolarity and tries to decide what's best for each vein. So I just thought that would be something nice to throw in so that you would kind of know what can go through certain things.
Well, excellent.
Wraps us up.
Excellent. My head is spinning. It's a lot of information for someone who's not clinical, but I surely really appreciate it. And it's been wonderful to hear. I failed at the beginning of today's presentation to read out to those of you who are calling in by phone or otherwise not able to see a screen. I failed to let you know our evaluation link. I'll do it now. It's at https://www.surveymonkey.com/r/ all uppercase letters, H as in Harry, Y, 5, F as in Frank, G as in girl, N as in Nancy, M as in Mary. And the password today, which is also the code word, is Ginger's company's name, To Advise. And that is the number 2, lowercase letters ADVISE. To Advise is today's password. Again, the survey, for those of you who need to make note, is https://www.surveymonkey.com/lowercase r/ all uppercase letters, H as in Harry, Y, 5, F as in Frank, G as in girl, N as in Nancy, M as in Mary, and the password is 2, the number 2, no space, the word advise, ADVISE. Excellent information, Ginger. You really filled my head, and I'm happy now for the weekend so I can relax my brain. But I'm so grateful, and I hope, Ginger, really, truly, I'd love to have you back if you have other topics you'd like lecture on. You're just a wonderful fount of information, and in a very intensive way. And so I know that every one of us who's had the pleasure, and Miss Townsend, Christine Townsend, said to you, awesome presentation, thanks so much. And Miss Siggers said, thank you, Ginger, great job and information. And we do thank you. I do want you to consider, you don't have to answer today, but I hope you'll come back. And I appreciate all of you who are here today. On Monday, we'll be back at noon. The presentation, I can't quite remember, but you'll see our calendar at Sean Barnes' page on carepatrol.com. Please sign up for us for that. I know it will be an excellent teaching as well. And again, thank you so much, Ginger. Tammy Till says excellent presentation. Everyone, I think, was bowled over, and thank you for sharing this Veterans Day with us. Again, if you or your family are in the service, we thank them. It is because of them that we were able to vote this week, and it's because of them that we live in a democracy. And we live, as you may know, in the greatest country on earth, and our military keeps us safe. So we appreciate you. Thank you all for being here. If there are no more questions, Ginger, do you have anything left to add?
Thank you for having me.
And now I think I've lost the ability to turn it off. Now, here we go. All right. Thank you all so much. If I can get my computer to work, which is always a big if, we'll see you next time.